someone says, oh, you look so good, that reinforces that they're treated differently based on how they look. And that, oh, someone says I look good, that means when I'm skinny or, when I'm manipulating my weight in this way consistent with the disease, I'm getting positive feedback. So because that texture feels funny, I then want to gag and I feel gross. Like I'm that repulsed by it.
Wow.
But the repulse level is at the intensity of something that we think objectively of, like a bowl of cockroaches. Like what would you do if you had to eat a bowl of cockroaches 5 times a day to survive?
Yes, I am on a weight loss shot for about 6 months and I'm down about 20 pounds.
Congratulations.
Disclaimer, that's me, not anyone. I can't say anyone will have the same impact, good, better, worse. The first thing people tell me is, were you going to be on it forever? I don't have a good answer for that.
Welcome back to another episode of That's an Issue. And this week we tackle the complicated issue of eating disorders. And we brought in the very well-experienced Dr. Malka Sears to explain a little more about what it is. It's not so simple. It's not like the other challenges that we discussed. It's multi-layered and very different from case to case. What she's seen and what's the plan that an individual, the family, even the community, what we could do to alleviate the challenge of eating disorders. You'll also hear a really super surprise guest in this episode to talk about their experience with managing their weight. You'll see. It's a little silly, and I think it helps make this episode a little more. I don't want to say the word fun, but I think that's what it is. Get a real raw experience. Here is their conversation.
Mental health, relationships, those are loaded topics and something that affects every part of our lives. But we aren't having enough open conversations about it.
And that's an issue.
You work with people who have eating disorders and other related things. Why is this so important?
It's really important for me to talk about eating disorders since eating disorders have the highest mortality rate and the least amount of resources available.
So what kind of resources?
Resources.
Like what is available, what's not available?
So we have evidence-based treatments available that through the research that has been done, but there are not as many providers that are trained in these evidence-based treatments compared to other psychiatric disorders.
Is it harder to become someone who treats these type of disorders than it is other types of issues?
It is a very specific kind of training compared to other
anxiety,
trainings.
Depression.
Yeah.
Right.
So,
what are the eating disorders, just for
so
my knowledge?
Eating disorders is an umbrella term for some kind of disturbance in eating that is significantly impacting someone's functioning. So that can be some like a restrictive low weight eating disorders like anorexia, as well as avoidant restrictive food intake disorder. It can be bulimia nervosa, binge eating disorder. There's something called other specified eating disorder, which basically entails someone who doesn't meet full criteria for, let's say, anorexia nervosa or bulimia nervosa, but they are experiencing enough symptoms that would require us to clinically intervene. Or there's something called unspecified, where it's not really sure. You don't really have enough information to understand, but there is something significant in terms of the eating that's causing distress or disturbance.
Does there need to be a medical component for it to be considered an eating disorder?
Not all eating disorders have a medical component, but what contributes to the highest mortality rate is that a lot of eating disorders do have a medical component to it, given that usually eating disturbances can cause some kind of malnutrition or precipitous weight loss, which also impacts the training, that the training requires also knowledge of medical, having medical information and knowledge and being able to collaborate with a multidisciplinary team, whether that is a medical provider like a pediatrician or internal medicine doctor. It could be a gastroenterologist. It can be an endocrinologist. Sometimes it can be a gynecologist or OBGYN. but you are interacting and collaborating, and of course a psychiatrist, but that's what makes it different than some of the other psychiatric disorders where you're really, and a dietitian. So you're really collaborating with a wide spectrum of disciplines.
Cool. Interesting.
So you work in private practice, and you'll tell us what you did before that, but in private practice, you are collaborating with all these other people for your specific patient.
Yeah.
Are they coming to you first, or first they went to the doctor and now the doctor's referring them to you? Like, how would the process work?
Yeah, it depends on the person. Sometimes they have enough insight, or there's enough of a disruption in their day-to-day life that they are self-referred, or they go to the doctor, they lost a lot of weight, or there's something medically going on. They rule out a primary medical condition, and then it comes to, this seems to be psychiatrically based. And then they get referred to me from the referring provider, whether it's one of those kinds of doctors.
So that's a quick question. There are the eating disorders that I'm familiar with, as you said, anorexia. That's where somebody thinks that they are overweight and they don't eat, and they get skinnier and skinnier and skinnier to a dangerous level. Right? Am I saying that
yeah,
in layman's terms?
Yeah.
And then bulimia is if you throw up the food you eat, so you will eat, but you're forced throwing up. Am I saying that?
Yeah, there's a little bit of nuances where both of them have in common. There's this significant fear of weight gain to the point where someone with anorexia, it doesn't understand the seriousness of the illness. So when they're restricting to the point where they either have a precipitous weight loss or weight loss that is dangerous, they're still viewing themselves as, like you said, as not consistent with everyone else around them.
Meaning someone with anorexia will look at themselves in the mirror and really believe that they are fat.
Yeah, they view themselves. It's a distorted perception. Essentially.
How does someone get to that? Like, how come they don't look at themselves like compared to where they were yesterday, or compared to even people that are what they would be considered skinny? Like, how does that, is that like a mental issue?
Yeah, I mean, essentially, if you think about something that you're so focused on, like if you view something at such a hyper-focused view, as opposed to looking at the bigger picture, you're essentially going to find something, like you're going to find something wrong with it. So someone who has anorexia nervosa, their perception of themselves and their body and appearance is distorted because they are so hyper-focused on certain areas to the point where they're not able to see, who they are
as a whole
picture. Because inevitably, when you're so focused on something, you're going to see some kind of flaw. And I think there's also reinforcing aspects to it. When you're restricting and you're losing weight, there is a neurobiological component to that where it activates the reward system in your brain. It emotionally, it can be very reinforcing for someone who's trying to cope with or avoid certain experiences. So it's not just itself the distortion of not seeing themselves in relation to others, but it's also the reinforcing aspects that come along with the disease.
Interesting.
And
what about other people, like telling them they look good?
So
I thought that's where you were going with reinforcing.
Yeah, I mean, that also can happen where, just based on external motivation, someone can be struggling. There are many, kind of proposed vulnerabilities of why someone can develop an eating disorder. There's no causal explanation, but there are some vulnerability factors of why someone can develop an eating disorder. One of them is if someone has really low self-esteem or really no sense of self, the function of an eating disorder can be a way to kind of view themselves in a way that feels good. It's something called an egosyntonic disease, which means that it attaches to their sense of self. So it essentially is a feel-good disease. So when someone is symptomatic of restriction, of preoccupation about their body, about their shape, and they see that when they're restricting, their body changes, it can be reinforcing and feel good. And then the external motivation, to your point, when someone says, "Oh, you look so good," that reinforces that they're treated differently based on how they look. And that, someone says I look good, that means when I'm skinny or, when I'm manipulating my weight in this way, consistent with the disease, I'm getting positive feedback.
You mentioned another eating disorder prior to the show, and I just forgot the name of it. But do you recall what that was?
Sure. Avoidant restrictive food intake disorder.
Right. So she said ARFID.
Oh,
It's
ARFID.
abbreviated as ARFID, but
okay,
the
got
actual name of it is avoidant restrictive food intake disorder.
And that's the catch-all? Is that what that is, or is that something else?
So it's interesting. ARFID is distinct from the other eating disorders that are kind of pretty common, is because there's no distortion in body image. There's no distortion or preoccupation with appearance. What's driving the restriction and the eating disturbances is essentially some kind of anxiety, is how we kind of conceptualize it. Whether it's fear of something averse happening while they're eating, like fear of choking, fear of vomiting, fear of abdominal pain, or it can just be eating when there's no hunger cues is really aversive to the point where it can elicit disgust. It could elicit this nervousness, this worry, or it can be that just eating is just, so that lack of interest in eating, or sensory concerns. Like,
and you feel like this is
the
a
texture,
right. Taste, smell, the color of it. And the reason why this is something that's considered important is it can cause nutritional deficiencies where someone can either also have a precipitous weight loss. So like they fall off their growth curve because it's a restrictive eating disorder where they're not eating and they're not gaining their nutritional needs met. So they may have to depend on supplementation or some kind of vitamin or something to meet their needs. Right. But the other component to it is not just nutritional, but they're functioning as in their day-to-day life, like psychologically and socially. If they're experiencing this amount of distress from eating certain foods, or socially, they can't engage in typical eating environments like school, camp, work, going on vacation, it can cause significant impairment, which what makes this, it's kind of like talked about as like extreme picky eating. That's essentially what it is, like clinical extreme picky eating. What makes that different than, kind of picky eating that would be developmentally
You're taking my
typical.
question.
Oh, sorry.
No, go.
Okay.
But I guess like a two-part question. When would ARFID be diagnosed? Like, I guess how young? And then going from there, like when is picky eating considered developmentally appropriate, normal? And when would you say, no, this is ARFID?
So it could be diagnosed, from my experience, I have diagnosed kids as young as 2 to 3 years old, because part of the factors that contribute it being a clinical level to the point where it needs clinical attention, as opposed to something that doesn't need intervention, is if it causes significant impact on the child where they can't function in developmentally appropriate situations and settings like school or camp or the day-to-day at home, or nutritionally, there's a concern where they either fall off their growth curve, they're not growing as much as they could.
What would a kid not want to eat? Like, what would you see? Like,
It varies. It could be palatable foods such as like chicken nuggets, mac and cheese, pizza, bagels and cream cheese, or it could be something that's a little bit more, not as palatable, something that could just be, whether it's something like that's commonly served in the house, like let's say cholent on Shabbos, or meatballs.
I feel like our kids would eat cereal every meal,
If we let.
Right. So I think that, it also could be what makes it clinically significant is there's a certain rigidity and inflexibility to be able to adapt to eating a variety of foods. And it's not just the foods itself. It could be the way they're eating the food. So in terms of there's certain rituals or it has to be a certain brand, or it has to be prepared in a certain presentation, certain temperature. So let's say a kid can eat all kinds of bread or all kinds of pizza, but it has to be, black to the point where it's really burnt. Or someone only eats like one brand of chicken nuggets. And if they were only given that one brand, they would be able to eat. But if you gave them another brand, they wouldn't be able to eat it. So from a functional standpoint, that's difficult for a parent, because if they can only eat that one brand, they're not able to eat.
Right.
All
The
kinds of
brand would
chicken.
really like it, but not
The brand would
parent.
like it.
Right.
But then the parent has to, what ends up happening is the parent always has to pack along that brand. And then what happens if the kid only eats it hot? In terms of level of functioning, only one brand of chicken nuggets, only steaming hot, is not very functional for a
Right.
child to eat.
Right. So that has to be
But-
nurture, right? Nature. I'm sorry. That's not something, this is something the kid is born with.
It's kind of a combination of both. Is, there's emerging research on this, because this is something that this disorder has only been coined in 2013. So there's a lot more research that we need to do as a field to really understand this. But we do understand right now is that there's a combination of biology, where some kids are just born to have a heightened sensory response. We kind of consider them like super tasters or super sensors, where just their sensory system is just at a heightened intensity compared to some other kids. So it could be the reason why there's a temperature preference is because they experience it that at a higher intensity than some other kids.
Oh, interesting.
Then there's the nurture component. If a kid is only given chicken nuggets, that one brand of chicken nuggets throughout their whole life, understandably, if there's a new brand of chicken nuggets, just because of lack of, kind of exposure, or, understandably, that may be more threatening for the child as they get older, because all they know is that
It's
one brand.
of chicken nuggets.
So meaning from a nurture piece, like what a parent could do is always be giving a variety of foods.
Yeah.
Like, meaning,
or
just in terms of doing your best as a parent.
yeah. And I think it's not something
Right.
we parents necessarily think about. Okay, so if I just happen to like this brand for whatever reason, I'm always going to buy that brand. But it's not just that. It's that the kid learning to eat chicken nuggets in all settings, where they go to school and they're given chicken nuggets for lunch, or they go to a friend's house and they have chicken nuggets there. That's a different brand. Those are all social experiences where they got to experience eating chicken nuggets in other settings where it essentially isn't threatening for them because it's familiar to them.
Does it make you sad to see like such a small kid struggling to eat? Like, that's got to be tough.
It's tough to see. I think any kind of eating disorder is
Right.
tough,
Right.
but I think what helps me stay strong is that I know there's treatment to help. That I know that while the kid is experiencing this level of distress, the parents are understandably burnt out and stressed. We have evidence-based approaches to help. And like I've
You've worked.
worked with, I've
Right.
worked
So
with.
I want you to tell us like what those are, but I want to just ask one more thing before
Sure.
that. Kids go through phases of like, I only want to eat this or I only want to eat that, which is normal.
Yeah.
Like, how long would the phase have to go for the parent to say, okay, this isn't a phase anymore, like this is a problem?
So that's a great question. Usually what determines that shift, that mindset shift, is one, the level of distress that the kid is experiencing. So if they're not able to soothe themselves, they're experiencing acute distress to the point that they're unconsolable. And it's happening for a long period of time. It's impacting their level of functioning. And it's just getting worse. So a lot of the times what ends up happening is like more foods get dropped, or the inflexible, rigid eating habits become bigger or generalized to other domains of food. That's usually a sign that, okay, this isn't just a phase anymore, because when it's a phase, you usually see some improvement or some kind of, that initial hesitance to try it or just lack of preference. But when you have you have a certain preferred food, it's not going to dramatically impact your ability to eat and function in that
Right.
setting as something that's more of an anxiety-driven response.
Would this come out at an older age, or this is exclusively coming out in younger kids?
I think now it's coming out younger just because there's more education about it. But I have seen people who have come to me who are adults now, and they're like, wow, I read about this condition and I had no idea about it. When I was younger, my parents just thought I was a picky eater. Understandably, they enabled it and accommodated it because that was the only thing I ate. And then now I'm in a setting where I'm working in a professional setting, or I'm dating someone, or I'm going out with my family, and I just realized I can't function and it's really impacting me.
But it would have been present when they were younger. So it's not something that just popping up at an older age.
So it's interesting because it depends on where the eating disturbance kind of derives from. If someone had a traumatic experience, let's say with eating, whether that's in the context of allergies or, aversive eating experience like vomiting or choking, that can maybe precipitate that, where there's no age range of where that can kind of just happen because it's circumstantial. But the ones where usually there's some kind of underlying discomfort, usually sensory concerns, or, this lack of interest in eating to the point where eating is such a chore, that can kind of evolve over time where, it's been accommodated, but then someone like an adult, it's like, wow, I never knew about this because understandably I've been accommodated my whole life and now I'm on my own. And there was also less research and education about this kind of condition back then. So, and people have been able to adapt, but it gets to a level of actually, this is causing me a lot of stress. And I realize this isn't typical.
Got it. Okay. So then how do you treat it?
Yeah. So how we treat it is a combination of an exposure approach as well as implementing various different kinds of additional strategies, whether it's cognitive behavioral work where we understand the difference between how certain thoughts, intrusive thoughts, are related to different levels of stress and how that impacts and contributes to the food avoidance.
Could you give us an example?
Sure.
Of something, I guess, that you've worked with.
Yeah. So,
could a thought be like, I'm going to choke?
Yeah. A thought can be fear driven, where it's like, I'm scared I'm going to choke, which could be evolved from many reasons. It could be because they sat in school and they saw someone else choke. It could be they felt a sensation in their throat, and that sensation in their throat when they were eating it was very threatening to the point where it then elicited the thought, am I going to choke? That sensation in my throat felt really uncomfortable, and I may have gagged and the food came out and everything was fine. But that was a really aversive experience for me that I thought I was going to choke. So because I had that aversive experience, I don't ever want to eat that food again. Or it could just be a disgust response, meaning like, I ate this food. It was so gross. It was so disgusting. I gagged, and it was really aversive for me that I'm never going to eat that again because I don't want to get sick. It's gross. Or it could be a new food that someone's presented with, and it's like, I don't know what that experience is going to be like. I don't know, meaning because I've never eaten that before, or it's unfamiliar, or it's different. It's a different form. So the thought that comes up and the feeling of worry comes up of like, I don't know what's going to happen. So because I don't know what's going to happen if I eat that, I'd rather not eat it.
I had this experience when I was younger and much more immature. And on Purim, I had a certain sweet wine and I drank way too much and I threw up, and I cannot even smell that wine. This is a certain semi-sweet that I received, and one whiff of that and I'm like gagging. Like, it's brutal.
Right. So that gag response is so aversive to the point where I rather not ever go near that again.
Oh, 100% can't go near that.
So
but not having that wine doesn't cause you distress or impact your functioning. So that's
exactly. But sometimes like the daily foods of cereal, mac and cheese, pizza, some of these like palatable foods that kids usually eat and are easily accessible can also be experienced at the level of like, ew, that's so gross. It feels like I'm eating a bowl of cockroaches. Like that's how intense.
But say that again. That a kid will eat a bowl of cereal and think it's an
example of an intense disgust response.
Wow. And how did that come about? Where did that?
A lot of the times the disgust response that kids experience, or even adults, I shouldn't just say kids, like adults as well, can be in the context of sensory concerns. Like, that feels gross in my mouth, or the meaning taste wise, or the texture feels funny in my mouth. So because that texture feels funny, I then want to gag and I feel gross. Like, I'm that repulsed by it.
Wow.
But the repulse level is at the intensity of something that we think objectively of, like a bowl of cockroaches. Like, what would you do if you had to eat a bowl of cockroaches 5 times a day to survive?
Oh, you're asking me a serious question.
Yeah. How would you do
That's
it?
such a great comparison.
I would
like
not
to put
eat.
yourself in
Yeah.
their shoes and to really understand how they're
Yeah.
I
feeling.
probably would not eat the bowl of cockroaches. to
Even though
survive.
that's the only food that you need to survive. You're on a desert island.
Probably die.
Okay. What would you do?
You would eat cockroaches?
I don't think so. I
So-
can't imagine, right?
So that's
how they
That's
feel,
an example
right.
of a disgust response that some kids feel. Not always is it disgust driven. It can sometimes be fear driven, like what those examples of like, I'm scared I'm going to eat that because I'm going to choke, or
I'm
I'm going to throw up, or I'm going to have GI symptoms.
So how do you fix
or,
that?
right.
through exposure.
Right.
Sorry, we went off. So through exposure work. So it's kind of a similar model to other anxiety-based disorders, where the more you increase the exposure to that uncomfortable or scary situation, the less that experience has that same response over time. So repeated exposure of intentionally eliciting that discomfort, which is given the bowl of cereal to the child over and over again to build up mastery over that anxiety response. But what's interesting is there's a distinction between disgust and fear. Like fear is is a fear response that the
Like
more
fear of
you're
flying.
like, let's say fear of flying. Like when you're going on the plane over and over again, your fear response decreases over time out of just familiarity of like, okay, I see that I'm on the plane, I'm safe. And the more you have that experience, the intensity of your anxiety goes down over time.
Okay.
But disgust is a bit different. Disgust is, you may always feel this kind of repulsed feeling of like, ew, gross. But we build up to the point of tolerating that experience, even though it's uncomfortable, that like kind of queasy
So
feeling.
it's like baby cockroaches.
Like
Like
baby
sugar
cockroach.
coated baby.
Or chocolate covered, but chocolate
Shut up.
covered.
Okay,
Yeah.
I want to ask a question about that.
Yeah.
Is there, like, the issue would be if there's many foods that they feel this way about, right? If it's one food,
If
then
it's
it
just
shouldn't
the wine,
be impacting them too much. And then is it even something to treat? Probably not.
right?
Right.
So that's the distinction.
So then let's say they have all these different foods that they feel is like cockroaches, and then you're doing this exposure approach and getting them to tolerate the foods. Do they need to tolerate all of them? Or could you just pick a few so they get to a level of function? And is that okay? Or is that like not giving the full treatment?
Yeah, it depends on the child and the goals. Like if let's say a parent and a child come in and they're like, my goal is to get my child to go to sleepaway camp, or my goal is to get my child to be able to eat at school or function at, their day-to-day activities, we would talk about, okay, what are the foods that are served at home? Commonly served at home? What are the foods that are commonly at school or at camp or whatever it is? And we would use those, how we would make a list, what we call a hierarchy, but essentially like a food map of a list of all the foods that usually when it's a parent-child based treatment, depending on the age, it'll be more parent-based. And then as the child is older or in adulthood, it'd be mainly the adult really choosing those foods and giving insights into that process. But it would be for a child, let's say, parents really giving that insight of, okay, I think these are the foods that are functional for them. Like for them to be able to interact in their day-to-day life like any other child their age. And then the child ranks, okay, how anxiety provoking, how stressful is this food for me? And a lot of the times there's not always a congruency between the parents think that the food is, a 10 out of 10 as in the highest level of function. They need to eat pizza to be able to go to birthday parties. They need to eat birthday cake. But from the child's perspective, it might be like, I'm totally fine not eating pizza for the rest of my life.
Right,
Why
like
do I need to eat pizza for the rest of my life?
Right. It would be like herring, I think. Would you ever
gross.
eat herring?
No.
Yeah.
No, right?
Like
It's
you don't need to eat herring.
I don't need to go for
like-
therapy to get to eat
like
herring.
Right.
there's the matches and the cream, and then there's
Yeah,
the red sauce.
Oh,
You
no,
sure
no,
you don't
no,
want?
definitely not. No, thank you.
Now, this.
No, so then what do you do in that case where the parents they need to have pizza because anytime they go to a friend's party, sleepover, whatever it is, they're going to serve pizza and then you're not going to eat anything. And the kid is like, I don't
A
care
lot
not
of
to
the
eat
times
pizza.
kids don't want to be in treatment because understandably it's aversive for them. So a lot of the times kids are very like, I'm totally fine functioning without these foods. I've been, accommodated. up until now, I don't really need to eat these foods. And some kids, there's actually a social influence where it's like, I see all my friends bring pizza for lunch. I can't eat pizza. I really want to eat pizza because I want to be able to eat pizza like all my friends. My friends ask me, why aren't you eating pizza? And it's like, I don't like pizza. And they're like, why? Who doesn't like pizza? And then the social component can actually be motivating for the child.
So is that
to
probably
try
an easier patient to work with?
So
when they're self-motivated?
So I think self-motivation can be helpful in trying in terms of willingness and motivation, but we don't necessarily need the child to want to do it, to want to do the food exposures. What we would need is, we may implement external motivators. We may, I would work with the parents on, kind of parent management skills, behavioral reinforcement strategies to help with external motivation when the child doesn't have any internal motivation.
Right.
And
meaning they'll get a prize? Or?
Yeah, that they'll get, we'll have the sticker chart, we'll have the prizes.
The bees.
As long as it's proportionate. They don't have to go and buy a whole, expansive, Xbox or whatever, they don't need to go all out. We want to make sure it's proportionate because then they max out after one food
what
exposure.
You get after an Xbox.
Like, okay, I had one bite of pizza. Now I get my Xbox. Then what? You're kind of stuck.
Right.
When you want to get them to eat the whole slice of pizza, not just one bite.
Right.
So it can help to have internal motivation, but it's not necessary.
So you think this...
We use the external motivators.
Sorry to interrupt, but you think that this is the primary issue in eating disorders that you're seeing?
I would say it's not the primary, but I think there's the least education about it, and there's the least amount of treatments that are well researched because it's a newer eating disorder. And I think especially what we talked about, where it's really hard to differentiate for a lot of families, not clinicians, but from like kind of a day-to-day experience. Even pediatricians even come to me and they're like, well, I thought it was kind of typical for, a toddler not to, to kind of demonstrate these kind of eating habits. I didn't think it was, clinical picky eating. And it makes sense because there's not a lot of outreach and education about this kind of thing. And because it kind of overlaps with kind of the typical, it's hard to kind of tease out unless the kid is so stressed. Then it's like, okay, we have to pay attention to this. This is causing so much
Or they're
disruption.
really not growing or gaining weight, like something more, something that's very obvious.
Yeah, because there's so much heterogeneity in terms of what this looks like. They don't have to fall off their growth curve to need, clinical attention.
Right. So when it comes to the other eating disorders, you would say your practice or the people that you work with, you're dealing more with people that are struggling with, let's say, bulimia or anorexia.
I think that's the case because there's a lot more resources and treatment providers out there for anorexia and bulimia and binge eating disorder. That it's not that I do see those people in my office, but when it comes to ARFID, there's really very even or more limited amount of places to go for that kind of treatment. Because just because someone treats anorexia nervosa or bulimia nervosa, they don't necessarily treat ARFID. So
it sounds very
it's very
it's a very
specialized.
Specific kind of treatment. It's not the same.
Yeah. And there's no kind of gold standard with anorexia and bulimia and binge eating disorder. There are gold standards out there.
What are they?
Yeah. So let's move on to that.
Okay. So for anorexia nervosa, it depends on, and even bulimia nervosa, it depends on if the individual is a child or an adult. FBT, family-based treatment, is the gold standard for adolescents. And for adults, there's enhanced CBT, enhanced cognitive behavioral therapy. There's also other modules that are very helpful given the nature of what an eating disorder entails, like DBT, so dialectical behavioral therapy can be helpful. ACT, acceptance commitment therapy, where you learn to accept certain feelings, mindfulness. So there are these other domains of treatment that you can incorporate within the gold standard of treatments, like enhanced cognitive behavioral therapy and family-based treatment. And then there's kind of the second line treatments of, if family-based treatment is not the right fit for a family, depending on the nature of how the eating disorder is manifesting for the person and the family dynamics. There's something called adolescent AFT, adolescent family treatment.
So
focused treatment, sorry. Yeah.
So
which is more individual. You're working with the adolescent individual as opposed to with the family. And it's more of a dynamic relational approach as opposed to charging. FBT is charging the family, the parents, with feeding their child because their child has no capacity to eat on their own, given that the disease essentially took over their body and they need it. And then gradually you give them more autonomy.
Right. So how young have you seen someone with anorexia? Like, what's like the youngest age that you've seen?
I've seen 9.
Wow.
9.
I think pre-puberty and early adolescence of emerging into puberty is a very vulnerable period.
For what reason?
Body changes, hormonal changes, social influences, many different reasons.
Matt, did this person know like there was something wrong?
So I would say the parents had a feeling. Usually what happens is there's some kind of abrupt shift in either the child's eating, the child's behavior, whether it's noticing a child is skipping meals, not eating as much, restricting, a significant shift in their eating patterns like restriction, precipitous weight changes, whether it's weight gain or weight loss, hiding food, being secretive around food, experiencing a certain level of distress around body image, around, let's say, like getting dressed, going places.
Hiding food, you mean like making believe you're eating, but like moving it aside?
Yeah, kind of showing that you're eating and then you're really throwing it out, or hiding food in the room, just being very secretive about food.
Wow. And this...
right, so then what would the parents do? Like, let's say the parents notice this happening. What should they do first?
So usually what happens is they try to address it with the child directly. And they're like, we're noticing, whether they noticed vomit in the toilet or they noticed their tray of food when they left the room was thrown out. What happened. And usually it could, depending on the child or the level of distress that they're feeling, they can get very defensive because they feel threatened. And understandably, parents are like, this is urgent. Like, what happened? Like, what did you do? And they assume that it's a willful process, when really what could be happening is that the child might not be knowing what's going on. It may not be something conscious that they could say, I threw up because I felt gross when I was eating that food, or I threw out my plate because I really didn't feel hungry. Not always can they articulate it. For some kids, they can. And they can be like, I noticed I felt this way. And they're able to label that feeling. Not always can children, especially depending on the level of development, can they articulate what's going on.
Like when you spoke with the patient, you were able, that's what the patient said to you? Like, what did they...
So depending on the patient's, for this particular patient, someone who's 9 presents very differently than someone who's 12 or 14, right. Where, you need to kind of use keep in mind their level of development in terms of their ability to reflect and label feelings.
Like 9 is really young.
9 is really young. 9, 10, where they may be able to reflect. I know that I felt this way. And I can sense that there's some distress around body image, or there's some distress about weight, to the point where it's preoccupying their brain constantly. Like when I say preoccupied, it means like when they wake up in the morning, they're thinking about their appearance. They're thinking about their body. It's like a little voice in your head that's constantly talking to you. You go get dressed, or you go brush your teeth. You're in front of a mirror, a reflective surface, constant chatter and, noise in your head. You go downstairs to get breakfast, constant chatter in your head of
that's what this person told you.
That's what an eating disorder
is.
It is. Yeah.
Wow.
And because it's egosyntonic, meaning it's consistent with their sense of self, it's very hard to reflect on, this is something wrong with me. Like, that's why, for example, in anorexia nervosa, they can't necessarily understand and appreciate the seriousness of what they're experiencing.
Wow.
Just because I vomited, why is that bad? I felt better. It made me feel better.
Wow. And this patient or patients that you see that are that age, are they overweight or that are generally skinny to begin with?
It depends on the nature of the eating disturbance. I've seen some kids who, are having trouble with eating to the point where it feels out of control, that they're eating to the point where they feel this loss of control, and they're objectively eating amount of food that's considered larger than, kind of a typical meal. So it's very stressful when you feel like you're eating. It's different than overeating, where you're eating objectively a large amount of food, like 4 or 5 course meal in a spin.
What? This is it. This is it.
Children can have this. Yeah.
Okay.
It's called binge. It's under the category of binge eating disorder, where a child can feel loss of control over eating, meaning I'm trying to put the 4 cookies down, but I can't put them down. I'll try to put them down, walk away. But all you're thinking about is those 4 cookies. You can't move on with the rest of your day and focus on work, focus on other areas of your life until you have those 4 cookies.
Right. No.
Like that's a sense of out of control, which is really stressful.
Right. For a kid, for sure.
For a kid, for an adult, and they're objectively eating, a large amount of foods. I can see that kind of eating disturbance in a child to the point where their doctor recommended them because they may be experiencing medical complications or just stress in general with eating. Or there can be a child who, lost a lot of weight in sleepaway camp and came back from sleepaway camp, and their parents find them vomiting in the bathroom, find them trying over exercising, skipping meals, and they went to their annual visit after sleepaway camp and they dropped 20 pounds.
And then we're assuming the person couldn't lose 20 pounds. Like 20 pounds wasn't a good thing.
Yeah, because they in terms of that weight, the precipitous weight loss, it's the amount of weight loss like in a short period of time, like the amount is significant, or it's that it was significant for their growth curve, meaning they were always in, let's say, the 50th percentile and they dropped to the 15th percentile or 20th percentile.
So folks who, let's say, use a drug that limits their intake, their desire to eat, does that make you nervous? Like, meaning if you there's this,
diet pill shots,
or this, there's one like Ozempic that we discussed prior to the show. But does that, the fact that you're decreasing chemically your desire to eat, does that increase
like the likelihood of developing an eating
I don't know,
disorder?
like you're basically you're reducing chemically
like appetite suppressants. Yeah. So I think specifically with Ozempic and medications that are out there for also medical purposes in terms of, metabolic reasons, I think that's something to take into consideration, where the appetite suppressant is a side effect of the gain of medically stabilizing whatever the condition is that it's treating. For example, that's common with ADHD stimulants as well, where someone can be prescribed a stimulant because it's kind of the same cost and benefits of, I may suppress my appetite by taking the stimulant, but it helps me focus and function in my day-to-day life. But the consequence of that is that it curbs your appetite to the point where, and there are even some kids who have ARFID and ADHD. It's a common co-occurring diseases that they already have a vulnerability of not eating, and then they have the medication that also on top of that curbs their appetite. So in that kind of situation, you kind of have to weigh the costs and benefits. If this child really needs to function because that's what really helps with managing their ADHD, what are other things we can do that can enhance this child's success where then they're still eating and meeting their nutritional needs? So I feel like it's the same thing with Ozempic or some of these other medications, where if there needs to be kind of a weighing of cost benefits, where if the medication is helping for the medical conditions, but the side effect is appetite suppressant, then we kind of have to figure out it's not good to suppress your appetite to the point where it could prevent you from meeting your nutritional goals. But if it's not dramatically impacting your day-to-day functioning, you're eating less, but you're still meeting your nutritional goals for the benefit of not having diabetes, that's important. But if it's serving as a diet pill, that's a different story.
You mentioned that you didn't like Ozempic.
I think from my experience, from what I've seen and read, Ozempic has been also advertised as a diet pill. I think diet pills in general, not specific to Ozempic, but just diet pills in general can be, dangerous.
Why?
Because if your body naturally needs to experience hunger cues. Hunger cues are important because it it helps you, it helps you be attuned to that you need more fuel. And everyone experiences hunger cues. I think that sometimes hunger cues are more threatening to people than others, because hunger cues can elicit that fear of like, oh, I'm going to overeat, or I'm associating hunger cues with feeling fat, or, and then feeling fat then becomes I am fat. So I think hunger cues, that sensation in your body, can be threatening to a lot of people, which is why it then leads to a diet pill. I want to curb my hunger cues, so this way I won't eat. And then if I don't eat, then I'll treat that concern and thoughts that I have around that.
Interesting. Do you mind if I bring on someone who willingly wants to join us, who is on Ozempic, that might be able to contribute to this discussion?
Sure.
Okay. Excuse me. First to do.
Yodi.
I'm not wearing a button-down shirt. I'm not wearing my Twillery.
No.
Shout out.
Twiller. Shout out.
We're talking about Ozempic. I don't know if you
And the
heard
doc-
us in the other room.
I heard you guys talking about grasshoppers or crickets or
Oh,
something.
yes. That was
Cockroaches.
Cockroaches. Sorry. Not kosher, right?
Yes, that's
Grasshoppers might be.
Oh.
Okay, there's
true.
not.
That would have been a
Oh,
better
I thought this was the kosher money kosher. Okay.
Okay.
Yes, I am on a weight loss shot for about 6 months, and I'm down about 20 pounds.
Congratulations.
Disclaimer,
Congratulations.
that's me, not anyone. I can't say anyone will have the same impact, good, better, worse. The first thing people tell me is, "Well, you're going to be on it forever?" I don't have a good answer for that. But right now, I'm taking 2 blood pressure medications, a cholesterol medication. So I want to try to get off of that, and part of that is weight loss.
Right.
So
Right.
that's why it's important to me. I'm on the second to lowest dose. So some people get on it and they're like, I want to lose a lot very quickly. I felt that there's nothing wrong with losing a few pounds a month.
Yeah.
You're heading in the right direction, right? So I've been on it. It's been great.
So,
Shout out to Shalom Droslitz, who's helping me with it.
Right. So Malka was
Yeah.
saying like weighing the pros and cons, which
Right.
is
Yeah.
exactly what you're saying. But then we were getting into a little bit where Yoni pulled you in,
Mm-hmm.
like I guess the psychological danger.
the question.
Am I don't know if I'm
Yeah,
saying it
meaning
correctly
that's-
where you were going with that.
Meaning the dependency on something external to help with weight loss, for that one factor. But I think that's if, I think you have to take into account the medical complications that, weight can help with in
Right.
terms of a weight loss methodology. But I think anything in extremes, understandably, you want to be mindful of doing something in an extreme versus kind of moderately or managed. Like I think some people, from where I was coming from, some people depend on, let's say, an external an external source, like let's say a diet pill, instead of maybe eating, trying to improve eating habits from, a behavioral standpoint, where that can maybe have lasting change, as opposed to once you stop the diet pill, how does that help you transition to maintaining a healthy, well-balanced lifestyle?
Yeah, that's a great point. I have not exercised anymore. Am I in the shot? We didn't even plan for this. You think that one
Oh.
gets me?
Here, I
Yeah.
can move over.
No, it's not you.
Hopefully, I think
Hopefully.
so.
Hey, how's it going? I have not exercised. I have a Peloton. We bought it. Now it just hangs laundry on it, right?
That's very useful.
But I'm not. I paused the subscription. I know that's how they get you. I think it's $48 a month. But I'm optimistic that when I'm ready to have a legitimate lifestyle change, I'm going to be in a much better place as
Right.
a result of this, almost like head start. When you're walking and the wind pushes you
Yeah.
on your back. That's what I
Yeah.
feel where I am now.
That makes sense, because
Yeah.
sometimes you need that facilitation to kind of get started.
And I was one who certainly needed. There are those. I saw somebody today and he's like, I'm down 20 pounds. So I start naming the different weight loss shots. And he's like, no, I did it naturally. I'm like, ooh, you did it naturally. There's a stigma, right?
Right.
You could have gotten right into it. Now, granted, it's expensive. It is
Yeah.
expensive. Not most of these weight loss shots are not designed for weight loss. Like you said, that it's
Right.
for pre-diabetes or diabetes. So there are industries now and companies that are solely focused. Am I like hijacking, or is
Not
this
at all.
okay?
No.
Okay.
Sharing.
That are designed to get you this from labs and, you know, working with insurance companies. But most insurance companies are not paying out for it. So it's out of pocket. I find though, and I do hear, and maybe I'm one of the people that shouldn't be on it, but those who say, I need to lose 5 pounds, 7 pounds. So I'm going on Ozempic. I think Hollywood has a bit of that going on.
Right.
And I'm by no means am I someone to talk because I'm in this shiny glass house. But, you know, I think there are legitimate conversations to have. But, you know, some people say, oh, Ellie, you're coming and saying that in a public forum. That's a little bit irresponsible because you don't know the risks, right? There are risks associated with this.
Yeah.
And I get that. But I think there's a head start. I think getting off medications, I think I'm not doing it purely so I can look good at my sister's wedding, right? Like,
Right.
But that would be fine if you did.
Right. Oh, is that the stamp of approval? No, I don't know.
No.
I want to get off these blood pressure medications. Now,
Right.
granted, it runs in my family, but if I can go back to my primary care doctor and say in my annual visit, I'm down 25 pounds, and he's like, look, and I looked at my cholesterol numbers. Now, granted, I'm on a cholesterol medication. Everything's heading in the right direction.
That's great.
Right. So I'm happy. I'm not increasing the dose. I'm losing steadily but slowly, and I feel like I'm in a good place. There are side effects,
Right.
you know, nausea, vomiting, diarrhea. There are things that come along with the territory, but you have to know, you know, you don't take the shot closest to Shabbos because you're going to eat foods and more, and you can get very sick if you
Right.
overeat. So I take it Monday morning, and that helps balance it. If I have nausea, the doctor prescribed me certain medications for that. There are things that work for me.
Ellen, you wanted to ask some questions?
Yeah, no, that makes sense of weighing out the costs and benefits, especially when there's a primary medical reason, and that's really the source of why it's prescribed.
The concern you had was that if somebody wasn't, didn't have, let's say, the medical reason and was using the, you know, the medicine to basically, you know, inhibit a feeling to eat.
Right.
And if you don't conquer that naturally, that could be a problem.
it could just be part of the eating disorder.
I think that when you're trying to, essentially when things are threatening, our initial response is to avoid that feeling, escape that feeling, make it go away. I think some people experience with hunger cues are viewed as threatening. Like, oh no, I feel my stomach rumbling. Oh no, I start feeling hungry. Oh no, I don't want to eat. Like there's this fear or uncertainty of, I don't know how much I'm going to eat. And because I don't know how much I'm going to eat, that feeling is so threatening to the point that I want to numb that feeling. I don't want to feel that feeling, even though hunger cues are healthy. They're just like any other feeling is functional. And just like a car can't run on no gas, you need that cue of, oh, the car is empty. The empty light goes on the gas. So does a hunger cue. When you experience a hunger cue, you need fuel. So to ignore or view that fuel monitor as threatening can be maladaptive in terms of harmful if you're just ignoring those cues that are natural to your body.
Sometimes I won't pick up on the cues. I'll go the entire day busy, and then nighttime comes around. So
And you won't feel hungry at all?
Not during the day, but once dinner comes around and I'm about an hour away, 7 o'clock, I didn't really eat. I just maybe had a coffee. So you know the term hungry and angry is hangry.
Yeah, hangry.
I am furious. I don't know if that's a word, but it's hungry and furious. And it hits you like crazy.
Yeah.
So that's something that I picked up on, and it's only happened a couple of times, and someone was like, "Hey, you're not yourself." And I'm like, "Wait, I don't feel like myself." But I didn't have those cues during the day.
Right.
But that
you need to
makes
set
sense.
alarms.
What?
That's the
like approach to that is to set alarms in your phone for every 3 hours to eat
Alarms.
something.
Exactly.
Yeah.
So I was going to say, when you're
Wow,
not
that's
everyone
crazy.
experiences hunger cues, especially when, whether it's a curbed appetite for whatever reason, whether it's an appetite suppressant, or sometimes when someone's malnourished, like someone with a low weight eating disorder, their hunger and satiety cues are out of whack, where you need some kind of structure to, okay, how do I fuel myself in an effective way? So we consider regular eating every 3 to 4 hours. That time interval of like, okay, refuel. Because if you have that gap of time where you're running on empty, understandably, that's going to impact you cognitively, emotionally, all aspects. You may not be productive because you may just be dizzy or experience those signs of like, you need fuel.
Right. Those experiences were few and far between. I find it very interesting. I feel like a kid again. When you're a kid, you don't really think about food.
Yeah.
Unless you're really hungry. But your mother has to call you in by the bungalow to come in. You have to eat. And you're like, Ma, I'm not hungry. And your mother's like, no, you had pizza bagels 8 hours ago. And you're like, Ma, I'm not hungry. And you didn't eat. Maybe you had a lollipop.
Right.
I feel like that. When you're hungry, you can't work. When you're eating, you're focused on the food. After you eat, you're tired. That's how I feel as an adult. Now, for 8 hours, I'm like, you're just focused on, if there's people listening on audio, right? That was me typing. You're very focused, but yeah, I think being proactive about setting alarms, being attuned to the cue, it's very easy to brush it to the side, and then you're like, okay, I got over the hunger.
Right. When you work with a patient with an eating disorder or just in general, the hunger cues are off, like you were saying, are you the person who helps them with that, or that's the dietitian? Like, whose role is like really what they're eating and how often? Like, is that you or is that someone else?
So it can be both, that given our different disciplines, but have common shared expertise. Sometimes for a patient, they may need a dietitian to create a meal plan based on their nutritional deficiencies. So they're really focusing on, okay, you need more protein because you're in, or more iron. Like, they'll be able to help with guiding the kinds of foods and eating a variety of foods based on the nutritional needs. Also from a calorie-based fuel perspective of like, if you need a certain level of fuel each day, how can we arrange that in your day-to-day? What I do in some of my work is I review food logs. Like, they'll write, people will log their foods, but it's not just about the foods. It's about when they're eating them. What's the context of them eating them? What do they feel when they're eating them? Do they feel bored? Do they feel stressed? Do they feel happy? Like, what's the context of their emotional experience? What thoughts do they have coming up? So we may overlap in terms of, okay, we're talking about food in both kind of disciplines, but I'm getting at more of the psychological component of, okay, when you ate those foods, what led to, let's say, a binge eating episode or a purge episode when someone would vomit, or, restricting the next day, where I'm looking at the intervention is really understanding eating patterns in the context of the day-to-day life, where a dietitian may categorize foods as like, okay, these are no foods. These are kind of yellow foods where I would eat sometimes. These are the green foods, and how can I incorporate those foods that I need for my nutrition?
But would that make them more like having someone with anorexia, right, that's preoccupied with food all day, and then having them write down what they eat? Would that make them more preoccupied?
So it depends, right? So it depends on if you're treating someone who's low weight as a child or an adult. Where someone who's a child, you're just focusing that would be FBT, the family-based treatment, where you're giving the parents, the child's not doing the logs. The parents are actually the ones calculating and creating and taking charge of the eating. So the child's not involved in that. But an adult with anorexia can be writing down those foods, but it's essentially an exposure for them to have to manage that experience when they're so used to avoiding and kind of taking themselves out of an eating experience because it's aversive. So it's therapeutic in that way.
I love the logo, by the way. That's I've never really focused on it.
Nice.
But it's subtle, cute, and it's homey. So +1,
Thank you.
+2. I do want to say a couple of things that come to mind. Number one is anyone that is going to consider weight loss shots, don't just go on Google and click a button and order them. There are a lot of fakes out there. You need to do it with a legitimate medical professional because A, you can get the wrong medication, and B, it might not be the right fit for you. So speak to your a primary care doctor. If you don't have one, get a physical. I'm a big fan of getting an annual physical. I think people forget that. And don't feel peer pressure, right? Just because people like Kiddish are talking about it or people are posting about it. I'm sure
really
that
cool
plays-
people like Ellie Langer.
Right,
on it.
exactly.
Yeah.
Like this is something that I felt was good for me. There are risks, right? And there are maybe risks we don't even know about.
Other risks. So talking about risks, do you think that that there's a risk for an eating disorder to come about from taking Ozempic or any of these? Like, can you get into like you lose 50 pounds in 2 weeks and all of a sudden your brain gets like changed in some capacities? Have you dealt with anyone who took medication and then that affected them and they have an eating disorder now?
Yeah, the short answer is yes, but it kind of depends. I think it depends on, if someone has that precipitous weight loss in a short period of time and then they're continuously used to not having hunger cues and then they go about continuously not eating, that will impact their health. As opposed to kind of having a more balanced lifestyle, which is what you were saying, that like, it's important to kind of balance out your eating habits where any extreme is not really helpful. So, but understandably, sometimes if it's not everyone, it's not to say that everyone, but sometimes it can be that someone has an experience where they lost a lot of, a significant amount of weight in a short period of time and it feels good. It's reinforcing, especially if they get external validation, like, wow, you look amazing. It can kind of put thoughts in your head. Potentially, not everyone is vulnerable to reacting in that way. I think some people are like, oh, wow, I'm getting so much reinforcement that people are treating me well. I need to continue this. Like, what would happen if I don't continue this? People are viewing me based on my appearance. It can endorse that. That doesn't mean everyone reacts that way to then, endorse disordered eating to the point where it impacts their health. That's not the case, but someone could be vulnerable from adopting that kind of what we call cognitive appraisal. Like they appraise that situation as how they interpret that situation based on that feedback.
I have seen from a couple of people that their gallbladder was removed because they lost so much weight and then gained it back, and the yo-yoing between the two they think may have led to that. So that's just one of the stories, and I'm sure if you look online there are others. So yeah, I you mentioned one in terms of the dangers, but like I've seen that firsthand. So people are like, you're crazy, so why are you doing this? You have to make a decision that works for you. And I was scared of this, but then when you see so many people doing it, it's like,
right.
wow.
But you have a medical rationale. Like I think that there's a lot of the benefits outweigh the risks in that kind of situation.
If I was to do it again, or if Yoni texted me daily, I would say exercise. You don't have to be on a high dose. If you can curb your appetite somewhat and take up walking, running, cardio, the people that do that expedite the weight loss in a healthy way much more than just relying on increased doses.
Right. I think there are less invasive ways, I would say, that you can try, but understandably they're aversive in the sense where it requires a lot of work. It requires a lot of commitment, which some people, they kind of like ration, like, okay, it's a lot easier to kind of take a pill than me trying this kind of behavioral intervention. Not everyone, for some people. And I think since a lot of people in today's society want that kind of quick fix, that's the least effortful and will give me the fastest results because that's based on society in general. I think that can lead to the appealing of a pill to kind of fix everything. But it's not even just with weight. We kind of have that with everything. If we had a magic pill to kind of fix everything, it's a lot simpler.
For sure.
Oh, yeah,
Oh,
for
100%.
sure.
People ask me, do you feel amazing? You look great. Do you feel amazing? And the honest answer is not really. Like, I feel like I'm down weight. I'm a little bit lighter on my feet. I'm like, maybe if I lost another 10 pounds. But I think exercise has so much mental benefit that even if I would just get off my couch once in a while and run for 10 minutes, brisk walking once a week, I think there would be so much added benefit that I don't want people to think, oh, just because you look great, you feel great.
Right. But that's a very good point, that some people fall into that trap of, if they think that people look good, they feel good, when really someone can look good and really they feel horrible and they're struggling inside.
Right. Especially for
eating. Yeah.
eating disorders.
Yeah.
Wow.
Yeah. I have been sleeping a lot better. I feel like I'm going to sleep a little bit earlier. It's hard to know what's correlation, causation, but I've gotten into a good habit. I am getting older. I'm turning 38 in a couple of weeks, but I'm still new at this. So, I'm learning my body. Initially, I didn't have reactions, but I think maybe with weight loss, maybe your metabolism changes a little bit. So I'm a little bit more sensitive eating certain foods, or if it's too close to Shabbos, like I said. So,
right.
That's my story. You guys want my social security number? What else?
No, thank you for joining us.
What was the crux of the cockroach thing?
Oh, you want to know?
Would you eat, if you were on a desert island and all you had was cockroaches to eat 5 times a day? Would you do it?
I mean,
to survive.
Yeah.
So why would you do that?
Yeah, I would. I'm optimistic I'll get off that desert island. So if that's what surviving entails, I
do not believe you. Sorry.
I don't know. I'm not in the situation.
No. So we can rate that as alive more stressful than dead. Is chocolate cockroaches easier than, let's say, salted cockroaches?
I'm a very hopeful person. So if the way I look at it is, if I eat the 5 cockroaches today, then maybe that cruise ship will pass by tonight, and it's the work I have to put in.
You would chew on a cockroach.
Do I have fire? Can I cook it?
No.
Chewing. Either it's swallowing it whole, or you got to chew it.
People that we're discussing, that people who are struggling with,
don't hide from the camera. They have to see your face.
No. People are struggling with eating disorders. That's how they view food that they don't want to eat.
Oh, really? As if it's disgusting?
It's an aversive disgust response.
Oh,
yeah.
wow.
Sometimes you can have a significant disgust response to food.
Interesting. I have the finance podcast, so this is completely different. I'm ready to be like, so how do you budget? I'm like thinking of the next question. I'm like, wait, we're talking about cockroaches, and that's like the core subject here. That's an issue, cockroaches.
So we're gonna bring Micah back for kosher money.
I hate olives. Won't eat olives. Maybe give me the cockroach over the olive.
Oh, really?
No olive. Just
it's coming out.
The olives?
No olives for me.
Wow.
Used to not like mushrooms. I'm into it, but.
So how'd you get into mushrooms when you used to not be into it?
I think your palate, your taste buds, you change. They mature over time. Like, what 7-year-old loves tomatoes?
I have foods that I eat now that I would never eat as a kid.
Like what?
Like cooked fruit.
We cook fruit? Is that a thing?
Yes. Apple crust.
Oh, apple.
Right?
Yeah.
My mother made apple crust my whole life. Would not touch it. Like, to me, that was disgusting. Cooked apples. Like,
right.
Ew. No. And then in seminary, every place you went, they served apple crust. I don't know if it's like an Israeli thing. And then you had to survive when you're in seminary. I just ate it, and now I love it.
That was your island. That was your cockroach.
Like, what 7-year-old eats tomatoes? I think you did. But, they're vegetables. Maybe just kids don't like them because it's not as tasty as sugar. But I think you mature. And part of that is your heart's a palm. I spit it out as a teenager. If I see it in a salad, I'll just pick at it and eat it. So something's changing.
There's a certain tolerance level that you built up there that, because what we do in treatment, our goal is not to change people's taste buds. I think that kind of happens by default, where the more you eat the heart's a palm when you've never eaten it, the more it's like, oh, maybe that wasn't as bad as I thought. Because we tend to have these kind of preconceived notions of like, I expect it's going to be gross, it's going to be disgusting. And then sometimes what happens is you always thought you wouldn't like it, and then you actually try it and it's not as bad as you anticipated, because things always seem worse sometimes when they actually are. Or it really was uncomfortable and it really was bad, but the more you have it, the more you build up a tolerance for it.
We understand how people have different taste buds, right? Like, we get it. You like cooked fruit. She doesn't like cooked fruit. But as we talk about opinions and facts and like life, this is more of a holistic point, not so much related to the topic. We're not as forgiving. We're always like, how do you not think like me, right? How do you have a different opinion? But with food, we completely get it, right? Well, I don't like that. Socially, that's normal. You're allowed to not like something, and that's okay.
But not always. Sometimes it's like, why don't you like pizza? Who doesn't like pizza?
I had a friend who didn't like soda in elementary school, and I could not understand soda.
Right.
And what ends up happening is parents are like, come on, eat it. It's so good. How do you not like pizza? Right. But what's happening for the child, or even an adult who you're sitting with who can't eat pizza, is viewing that as the cockroaches. That's how aversive. Or it's kind of like, I'm scared to eat pizza because the crust is really hard and I'm scared I'm going to choke. Or the one time I had pizza, I got food poisoning, so I will never have pizza again.
So we covered weight loss shots. What else is on the agenda? Did you guys cover everything, or there's more to it?
This was pretty much.
There's definitely more, but
more.
we're gonna let Malka go have her date night with her husband.
Oh, okay. Are you local, or you're traveling now?
No, we are going back to Jersey, but we're open to hearing since we're on this side of the bridge.
Got it. Contact info. We did all that, all the good stuff.
Yeah.
Oh, okay. Bye, everyone. Listen to my podcast.
Okay. Thank you so much for joining.
Thank you for having me.
Thank you so much for watching or listening to this week's episode of That's an Issue. If you enjoy this show, go ahead and subscribe on YouTube, Spotify, Apple, wherever it is. Whoever sent it to you, you got to subscribe so you'll get the next month's episode. We have great guests coming up. And if you haven't yet seen our new Living L'Chaim show, Podcast Therapy, with Dr. Shlomo Zimmerman, I, Yaakov Linger, am a guest on the first episode where I open up about one of the biggest challenges of my life. So you could go ahead and click on the link below to see that. We love your suggestions when it comes to That's an Issue. And unfortunately, there are many issues that we need to tackle. So you could go to livinglchaim.com/suggest to let us know which person, which therapist, psychologist, maybe someone who's gone through experience can be here, sit here, and tell us and tell the world more about how to navigate that issue. Thank you for watching. Thank you for listening. And remember to stay safe. L'chaim. Living L'chaim.